So good morning, everyone. Welcome to Elder Abuse Ontario's webinar. How do we get to safety planning? Exploring questions when domestic violence, cognitive impairment, and caregiving overlap. I'm pleased today to be with my colleague, Rochelle Vassal, who's the Central West Regional Consultant, as well as Margaret McPherson with the Center for Research and Education on Violence Against Women and Children from the University of Western University, and Sarah Cook, who's a public education coordinator with the Alzheimer's Society of Peterborough, Kawartha Lakes, Northumberland, and Haliburton counties. So before we get started, I want to go over some logistics of our webinar. Everyone will be on mute during the webinar session, and we are recording this session. It will be posted on the website within the next day or two, where you can view the session after the fact. If you have any questions as we go along, and we will be asking for comments and discussion throughout the webinar, you can post those on the question or chat box on the left or the right side of your screen, and we'll be monitoring that throughout the webinar. So at some points, if we're able to unmute the individual that has asked a question just for further clarification, we may be able to do that as we go through the session. We will be leaving time at the end of the webinar for question and answers as well. And I know that we do have some polling questions in the webinar for your feedback included. You'll be prompted at the end of the webinar for an evaluation, and we hope that you'll take some time, a couple minutes, just to give us feedback on the evaluation and issues that you might like to see in future webinars. And we will be sending information on the PowerPoint electronically. You will see on the handout section at the bottom of your little screen there where you can download the PowerPoint if you'd like to follow along and take notes with the slides as well. And the speaker contact information is at the back of the presentation, so you can connect further with the speakers after we're completed. So I do want to acknowledge that the safety planning toolkit that we had developed was a collaboration with METRAC and the Law Foundation of Ontario. And we also recently partnered with the Alzheimer's Society of Ontario to adapt the toolkit to include issues around dementia. And that will be continually updated as we move through and develop more content and knowledge around this issue. So today's objectives for the webinar is really an exploratory discussion and getting feedback not only from our presenters but also from you as participants, looking at dementia and elder abuse and focusing on how dementia can increase risk of abuse, looking at domestic violence and elder abuse and family violence, exploring the differences and similarities between those dynamics of the different particular forms of abuse, how the sectors approach and define risk, and we all have a different perspective based on if we're coming from a justice or health or social services perspective. So our speakers will discuss that. And then lastly, we'll address how do we address the complexities and move forward together. We're not saying that we have all the answers. This is really, as we indicated, that this is really an exploratory discussion. We really haven't delved into the dynamics around the issue of domestic violence and dementia and caregiving and our work. And we're hoping that we can build on this as a part of a series of webinars. So this is the first of 3 that we are planning. The 2 will be in the next year, and further building on the content and knowledge that we develop from this webinar, as well as additional research and knowledge that we gain from our outreach to community partners. So just a little bit about who we are as an organization for those who aren't familiar with Elder Abuse Ontario. Well, our mission is to create an Ontario where seniors are free from abuse through awareness, education, training, collaboration, service delivery, and advocacy. We are a nonprofit organization, and we started implementing Ontario's strategy to combat elder abuse in 2002, where we were given the responsibility to implement the Ontario strategy to combat elder abuse, which is funded through the province of Ontario under the Ministry of Seniors and Accessibility. And we continue to implement that now. And again, our 3 priorities that we work under our strategy since the inception is coordinating community response, doing training and public education and awareness. So we work with our community partners to do outreach to improve our responses in local areas, as we know services are different. And we do training and education, and webinars are a key component of that delivery of training. And we do a lot of public education campaigns and awareness initiatives. And many people may be aware of the It's Not Right program, which Margaret was a lead in the development of that program. As elder abuse consultants, we do have 7 regional consultants, and our role, the one thing that we are limited in doing is actually case management of cases. However, what we do play a key role in is navigating services and supports and providing options for individuals to navigate the system and explore the issues that they may be having that are complex and not knowing sort of how to get resolution to the situations that they're involved in, whether that's community long-term care or retirement home. We support over 40 local elder abuse networks and committees in your region. If you're not connected to a network and you want to join one, please let Rochelle or I know, and we can connect you to one of those networks in your area. And we do a lot of outreach and activities to seniors groups in our communities, and we're furthering the cause to prevent elder abuse through conferences and events. So we do regional conferences, and we also have annualized provincial conference every other year that we do, and we mainly have those in Toronto. So it gives me great pleasure to introduce our speakers this morning. So as I indicated, we're joined by Margaret McPherson and Sarah Kirk. So Margaret is a research associate, as I indicated, with the Centre for Research and Education on Violence Against Women and Children. She's also the lead on the It's Not Right Neighbors, Friends, and Families of Older Adults. And she was the lead in terms of the development of that whole program, not only in Ontario, but also from a Canadian perspective. So worked with partners across Canada to develop that program, and has traveled in many directions across our great country to implement that, and has been a sustainable project or a sustainable program across territories as well as provinces. Sarah is the Public Education Coordinator for the Alzheimer's Society of Peterborough, Kawartha Lakes, Haliburton, and Northumberland. She is a person-centered agency dedicated to advocating for and improving the quality of life for those affected by Alzheimer's disease and other dementias throughout their journey. The Society provides support services, education, and advocacy free of charge, and offers help for today, hope for tomorrow for many individuals and families touched by the disease. Sarah has been with the Alzheimer's Society for more than 16 years and in the role of Public Education Coordinator for over 14 years. Sarah has a Bachelor of Sociology degree from Trent University, and also has her Bachelor of Education degree from Queen's University. She also enjoys going out to do into the public to do awareness and to educate individuals, social agencies, and professionals about Alzheimer's disease and other dementias, to offer information about how to keep our brains as healthy as possible as we age. So again, thank you both for joining us today. So I'm going to turn it over to Sarah to give us an overview of the Alzheimer's Society and issues around dementia. And then we will have Rochelle speak, and then Margaret McPherson as well. So Sarah?
Okay, thank you, Ryan, and good day to you all, and thanks for that warm introduction. I'm really happy to be presenting on behalf of the Alzheimer's Society today and to be participating in this really important webinar. I thought I'd begin by just giving you a bit of background about the Alzheimer's Society of Ontario and how the organization supports people living with dementia. So the Alzheimer's Society of Ontario was founded in 1983, and it is the province's leading care and research charity dedicated to supporting people with dementia in 4 main areas. So first of all, in providing care, support, information, and education for people living with dementia. Secondly, in funding research into finding a cause and cure. Third, educating decision makers about the importance of improving healthcare services and supports for people with dementia. And then fourth, increasing awareness about dementia and its impact. I represent one of 29 societies across Ontario, and our big claim to fame is that we have the biggest name of all the societies. As Rayanne said, we're the Alzheimer's Society of Peterborough, Kawartha Lakes, Northumberland, and Haliburton. So, yes, and being one of 29 societies, our mandate really is to offer help for today through the programs and services for people living with dementia, their family members and care partners, and hope for tomorrow by funding research into the cause and the cure. So one of the biggest, questions that I get asked, lots of folks say, we're hearing a lot about dementia, we're hearing a lot about Alzheimer's disease, we're hearing that this really is a rising tide, but how prevalent really is it? But it is a rising tide. Right now, 564,000 Canadians are estimated to be living with some form of dementia or cognitive impairment. So to put that into a ratio, we're really looking at approximately 1 in 11 Canadians that are living with this disease. For every person that's diagnosed with dementia, we often say that there's at least 10 others that are impacted by that diagnosis. So whether they're a family member, whether they're a care partner, a friend, a neighbor, a coworker, it is really a far-reaching and difficult disease for many people. Approximately 25,000 new cases are diagnosed each and every year, and that's a pretty staggering number. By 2031, it's actually expected that 937,000 Canadians will be living with some form of dementia, and that's an increase of 66%. So there is that rising tide that we are definitely witnessing. And it's important also to note that 1 in 5 Canadians have experience caring for someone that's living with a form of dementia. So we're also noting, that there are many caregivers that are being affected by this rising tide. So that's some numbers for, to see how it's impacting Canada. Let's look at the numbers, provincially. And I think it's important to also keep in mind that as we go through these stats, that many Ontarians are living with dementia in the community, so they're living in their homes, and as a result, they may be supported by family members or care partners that are providing that support. So it's currently estimated that close to 228,000 Ontarians are currently living with dementia. And as Ontario's population continues to age, it's expected that this number will rise to 255,000 people by 2020, by the year 2020, and over 430,000 people by the year 2038. So it's a significant increase. And interestingly, approximately 64% of people that are diagnosed with dementia are actually women. And so when you think about that, that's nearly, 2/3 of those that are living with dementia are women. And I'm often asked why the reason is that it's mostly women. So there's a few different reasons that people speculate about. So one of the most common ones is that women are living longer, and therefore they're living long enough to increase their risk of developing dementia. So that's one perspective. Another perspective, and actually the data is there to support it, is that women are at a greater risk of developing vascular issues. So they're at a greater risk for things like heart disease. And unfortunately, the second most common form of dementia next to Alzheimer's disease is the vascular type of dementia. And so we do see women at a greater risk of that particular type. There's a lot of speculation that it might be the effects of stress on women as well. Women have traditionally been, the problem solvers, the nurturers in families. They carry a lot of those stresses and strains and burdens on their very capable shoulders, but long-term stress can sometimes increase that risk of dementia. And then another area that they're currently looking at is the hormonal changes as women age. So that's an area that's being investigated. So, but yes, it's important to recognize that women, it's predominantly women that are affected by dementia. So what is dementia actually? There's a lot of speculation out there. Over the years, we've had many different definitions or thoughts about what it really means to have dementia. But the term dementia actually describes a set of symptoms that can occur when a person's brain is affected by certain diseases, certain disorders, or conditions. And as a result of the brain changes that happen with the progression of dementia, a person can experience lots of different symptoms that include changes in their cognitive abilities. And it's important to note that these changes are beyond the person's control. They are, in fact, a result of the disease process. So we can see that many of the symptoms include changes in the person's memory. So often it begins with short-term memory loss, and eventually it will affect the long-term memory as well. We see changes in the person's thinking abilities, their concentration, their ability to focus on a task for a period of time. We also see changes in the person's judgment and insight and self-awareness. So those types of changes can pose, serious threats to the person's safety if they're not judging what's appropriate or safe to do in a given situation. It also affects their ability to problem solve and to think through issues and to find, suitable solutions. And in general, it does affect the person's day-to-day functioning. So it makes it more difficult at times for them to perform activities of daily living and to continue doing some of the same activities that they've always enjoyed doing. They may have more challenges with these types of activities. I think what's important to realize, a lot of folks say I'm losing patience with my husband or my mom or my dad who I'm caring for because, I'm seeing changes in this person and they're repeating, the same question and they're not listening to the directions that I'm giving them. And it can be very frustrating for caregivers because when we look at somebody with dementia, it's not that we can easily tell by looking at them that there's changes that are happening. I often use the example of a person in a cast. If they have a cast on their leg, we have the physical, the visual clue that that person has likely broken their leg. We have certain thoughts about, how to support that person based on that. We don't have assumptions that they're going to be able to run and jump and do backflips and kick a soccer ball and, to do even to drive a car, because it's a physical thing that we can see. And where it's very difficult for a lot of people to understand the changes in dementia, it's because we can't see inside the brain. We can't see the changes that are going on there. But I assure you that those changes are significant and they do impact the person's ability to act, to respond, to communicate the way that they once did. So, that's important. And sometimes even with family members that are struggling to understand that, I will often say, with permission, can I show you a picture of a brain that's being compromised by dementia? It helps sometimes to look at that, to really see that the person isn't just doing it on purpose. They're not being resistant to, communication or, they're not repeating themselves just for the sake of repeating themselves. It's a brain change. So one of the objectives of this webinar today is really to look at how dementia can impact on the risk of abuse. If we look to the following quote, we can understand that the presence of dementia symptoms can often affect the person's safety and well-being. So people with dementia, the quote says, people with dementia are more vulnerable to situations of abuse and neglect. On the one hand, increasing dependency on others and deteriorating social networks leave the person more isolated, creating a context that is ripe for becoming abusive. Simultaneously, cognitive difficulties interfere with the ability to take action. So, for example, the person may have difficulty organizing to leave or seek support. So sometimes when a person with dementia becomes socially isolated due to declining relationships, due to declining social networks, other cognitive changes, and often the ability to understand and remember, they may be at a much greater risk of abuse. With brain changes and symptoms such as not being able to remember, not being able to use reasoning or judgment or insight, perceptual changes of their environment, the fact that they often require more assistance for those activities of daily living, a person with dementia may become much more dependent on a family member or on a care partner, and therefore that dependency can create a greater risk of being abused by that person. So dependency can often result in greater stress and increased demands on the caregiver, And certainly we see every day how caregiver stress and potential burnout can become a major issue. So if you think about that at the same time, due to some of the cognitive changes such as aphasia, right, or loss of language abilities, we often see a condition called agnosia where the person loses recognition and short-term memory loss. It can be really difficult for the person with dementia to report instances of abuse or to seek support from agencies that might be available to assist them. And as a result, they become much more vulnerable. So if we look to responsive behaviors in order to really develop a better understanding of the complex issue of dementia and abuse, it is helpful to explore responsive behaviors and why they may occur. In the past, many of you may recall that the term challenging behaviors has often been used to describe the behaviors that a person with dementia may demonstrate. Now, there's no denying that the behaviors that a person with dementia, those behaviors that they may exhibit, can be challenging at times. There's no denying that. But what we have found is that the term challenging behaviors has often implied that the person with dementia is really doing it to be challenging, and that's not the case. We know so much more about the link between the brain and behavior than ever before, and we now reframe behaviors in a very different light. Behaviors can occur in response to something, which brings us to the reason for the term responsive behaviors. And responsive behaviors is a very person-centered and respectful term. This is a term that's preferred by persons with dementia, representing how their actions, words, and gestures are a response, often intentional, that express something important about their personal, social, or physical environment. Responsive behaviors are really the result of changes that are happening in the brain that affect the person's memory, that affects their judgment, their mood, and their behavior. And as dementia progresses, we see these brain changes increasing over time. Responsive behaviors follows three main principles. Personal expressions can include the words a person may use, their gestures and their actions, and each personal expression has a meaning behind it. It's really important to recognize that. It doesn't just happen out of the blue or for no reason. It's often intentional, as we mentioned before. Personal expressions are often intended to communicate meanings, to express an unmet need or a concern of some kind. And so we as the care partners or service providers often need to put our detective hats on to try and really determine the meaning behind the message that is being sent to us. With greater knowledge and greater understanding, we can succeed in providing the best possible support to that person. So in other words, in order to understand the meaning behind the person's personal expressions, we really have to think about the possible factors that exist that might be influencing his or her behavior. Can we identify triggers in the environment that might cause the person to respond the way that they are? Are we understanding the meaning behind their message? Are we paying attention to the words that they're trying to use as well as the emotions behind them? Are we misunderstanding a need that they're trying to communicate to us, or are we maybe dismissing it as unimportant or irrelevant? Is there a way that we can change our response to better meet the needs of the person with dementia? And there's a really helpful resource that I just want to mention. It's called the Shifting Focus booklet, and it's included in the resource section of our notes today. And you can find it at shiftingfocus.ca. There's a short form of the booklet, and there's also a long form. And there's some great information in there about supporting people with responsive behaviors, finding the best ways, to address those behaviors, the do's and don'ts. It's a really helpful document that I definitely recommend that you check out, and it's at shiftingfocus.ca. A little bit more about responsive behaviors. So, responsive behaviors can often be difficult for care partners and family members to respond to. Caregivers often report that responsive behaviors represent some of the greatest challenges that they will experience while supporting or caring for the person. A common question that I often receive is, do I need to address the behavior, or will that actually make it worse or cause them more anxiety? Can I let it go if it's not hurting the person, or if it's not hurting anyone else? Will addressing the behavior actually do more harm than good? Or will it elicit more behaviors and actually worsen the behavior? If the behavior is not a problem for the person, it may be okay to let it go. Every situation is a little bit different. But two of my favorite phrases that I've often shared with care partners is choose your battles, and sometimes doing nothing is having a plan. And if it's not really harming, the person or anyone around them, sometimes we can let it go. One thing remains very clear. In order to truly understand the behaviors that a person may be demonstrating, we really need to understand the whole person. We need to avoid looking at the person with dementia as being defined by their disease. They are a person that's made up of, many different parts, and the more we understand the whole person, the better the support that we can provide to that individual. So I'm now going to take this opportunity just to turn it over to Rochella, who is going to show us the different pieces of the person.
Absolutely. And I think, thank you, Sarah, for laying the foundation, because oftentimes when we're out and we're delivering education and training, people will use the term aggressive. The person with dementia, is being aggressive, or, they're being abusive, and they really don't have the framework to understand how the dementia impacts their behavior. So thank you for explaining responsive behaviors. So oftentimes people that are working with older adults with dementia, we use the PIECES framework. And initially, PIECES began in 1997, initially as a response to complex cases, specifically in long-term care. And really, it's being used outside of long-term care and in the community, and it provides a framework for assessment and supportive care strategies. And it uses a person-directed approach. And it focuses on the, interdisciplinary teams, interprofessional communication and collaboration. And it really helps us as service providers to use a common language. So if we're all using PIECES, for people that are working as counselors at the Alzheimer's Society, as educators, as people that are working in the hospitals and the community, it gives you a better understanding in terms of what the person is experiencing. So you're going to look at the person's physical needs and capabilities, their intellectual needs, so what changes have occurred as a result to the dementia, their emotional state, do they have any underlying mental health issues, depression as a result of the dementia. What are their capabilities? What are their capabilities in terms of their activities of daily living, their instrumental activities of daily living? Are they capable to make specific decisions? Do they have somebody else that helps them with making certain decisions? Looking at the environment, are they in the community? Are they in a long-term care home or retirement home? And those other, environmental things that could trigger some responsive behaviors around, exit seeking or wandering. And then looking at the social aspect, what type of supports do they have? Do they have formal care or informal care? Do they have a power of attorney for property and finance, or a power of attorney for personal care? Are there specific cultural needs that we also need to look into? So it really provides, a really holistic view of understanding who the person is outside of their label, outside of their diagnosis of dementia. And it supports us in looking at some shared solution finding and looking at what we can do to support the person. So if we go to the next slide, part of the PIECES framework involves, looking at the risks. And, the risks include, roaming, wandering, imminent physical risk of harm, which can include frailty, delirium, falls, fire or firearms, suicidal ideation, kinship issues. So are there any issues around, abuse or risk of abuse or risk of harm? Are there issues around the power of attorney, the substitute decision maker? Was there any history potentially of intimate partner violence, any history of child abuse, and now the adult child is caring for, their elderly parent? Is anyone dependent on the older person who has dementia? So what are the relationships, and how does that potentially pose a risk of harm? And then we have the self-neglect, where the person might be self-medicating, or they might be at risk, under other areas. So risk helps us to look at the degree of risk, and is the risk escalating, and what do we need to focus our interventions on. So this is taken from Mary Lou Harrigan, who worked with the Alzheimer's Society of Canada to do a literature review on the intersection between older adult abuse and dementia in 2010. And part of her literature review looked at the increased risk or prevalence for persons with dementia, and that it's much higher than older adults who don't have dementia. So they also talk about in the literature review prevention strategies. And, if you look at the work that the Alzheimer's Societies, the chapters do across the province, they're really doing a lot of work in terms of prevention, because the focus is on education to caregivers, as Sarah talked about, education to help them understand the changing needs of the person with dementia, helping them understand where the behavior could be coming from. We have the Behavioral Supports Ontario teams that are working across the province in different capacities to support family members and caregivers to understand the meaning behind the behavior, and how they could look at potential, triggers to behavior and mitigate those triggers. And then there's some really great support groups that are being offered by the Alzheimer's Societies for, family caregivers, spousal caregivers. They have education and support groups that really help, foster a sense of community for, family members who are collectively struggling with caring for somebody with dementia. And then they also do a really good job of helping, caregivers understand what supports are available to them and how do they access those supports. So when we're looking at reporting, and Sarah kind of talked about how some of those changes in the person with dementia can create a barrier for them to report elder abuse. So she mentioned communication issues like aphasia, short-term memory loss, but there's also those other barriers that, anyone, regardless if you have a cognitive impairment or not, or people are afraid of what's going to happen. They're not sure what the police can do or what agencies can do to support them. There's a huge fear of going into a long-term care home, shame and fear of, what's going to happen to the perpetrator, the person who's behaving abusively, or, the fact that people will find out what's happening to them. And then there's that diminished capacity to understand how to navigate the services. So if they do call the police, going down to the station and making a statement, and if they're going to pursue charges, going to court, like this is a huge process that's hard for a person that doesn't have a cognitive impairment to navigate. And then when we look at why should we all be concerned? Well, we should all be concerned because there is no mandatory reporting in the community in the province of Ontario. So in some other provinces, we do have mandatory reporting of elder abuse. We have adult protective services. We have the infrastructure to, respond. But in Ontario, we don't. And so really, the obligation, relies on all of us. So you might have somebody that is going into somebody's home as an occupational therapist working for the Lynn Home and Community Care. They're not working necessarily in elder abuse, in the elder abuse capacity, but they could recognize the warning signs, and then they have that obligation to have the conversation with the older adult and to feel comfortable to have that conversation and to know where to refer that person for support. So it really rests on us as social service providers, healthcare providers, to work together to support older adults who are at risk of abuse. We do have mandatory reporting in all of our long-term care homes under Section 24 of the Long-Term Care Homes Act, and we're talking about reporting directly to the Ministry of Health and Long-Term Care Action Line. You can see the number there on the slide. And we're talking about abuse perpetrated by anyone. So it could be, the person who's behaving abusively could be a staff member, it could be a volunteer, it could be a third-party contracted agency that goes in to provide companionship. It could be the family member. So everyone has a duty to report. The only exception is the other residents that live in the long-term care home. So we all have a duty to report, and we have a duty to report abuse perpetrated by anyone. Similarly, in our retirement homes, under the Retirement Homes Act, we have Section 75. Same thing, anyone that sees or suspects abuse must report to the retirement homes regulatory authority. And again, it's abuse perpetrated by anyone, and we're all obligated to call except for the other residents that live in the retirement home. And if you go to the Ministry of Health and Long-Term Care website or the Retirement Homes Regulatory Authority website, you can actually look up the different facilities, and you can see if there have been any complaints and if those complaints have been verified. So that's public record for people. It just doesn't provide any identifiers. So keeping in mind that there's no mandatory reporting in the community, we have to work with the older adult, and we have to respect their right to live at risk. We respect all of the rights that they have under the Ontario Human Rights Code. We're not taking a paternalistic approach, in pressuring them to do things that they may not be ready to do. We respect, their choice, and it is a hard balance. It is a very hard balance between autonomy and safety, and I think many of us that are working in the field really struggle with that balance of looking at the risk and then also trying to respect our clients' autonomy. So it really comes down to capacity. And, in Ontario, we presume that all older adults are capable unless we have proof otherwise. And capacity is a legal definition that, it's two parts. So it's the ability to understand the information that is relevant to the decision being made, and the ability to understand the foreseeable consequences of making a decision or not making a decision. And so, we look at the Healthcare Consent Act, we look at the Substitute Decisions Act. Capacity is not global, it's specific to the decision or the treatment or the referral that we're proposing. And, one of the things that is helpful is if you're not sure about a person's capacity, is we do have the Capacity Assessment Office, and you can arrange with your client to have a capacity assessment. There is a fee associated with capacity assessments, but there are also subsidies available. Keeping in mind that your client will have to consent to be assessed. So, we have a lot of materials on capacity, and we've done webinars in the past. So if you want to find out more, I would encourage you to go to their website or to contact their office about the process. And then, what do we do with incapable older adults? So people that are incapable of making decisions around their property and finance or their personal care, and they have a power of attorney for property and finance, or they have a power of attorney for personal care, or maybe they have a substitute decision maker and they can't revoke that power of attorney. So in these instances, if you suspect that the power of attorney or the substitute decision maker is the person that's behaving abusively, you can contact the Office of the Public Guardian and Trustees and contact their investigation unit. They will investigate abuse of an incapable older adult, and if there are, risks of serious adverse effects. So the person is at risk of eviction, the person is at risk of a medical crisis if there is no intervention. So now I'm going to pass this over to Margaret, our last speaker.
Okay. Thank you, Rochella. So thanks everyone for being on this call today and for joining us in, sort of thinking about these things side by side. So I appreciate Sarah and Rochella's discussion about dementia. It sort of sets me thinking about how domestic violence, when it overlaps with a situation of dementia, brings a whole other perspective to the situation. And so that's what I'm going to do for the next few minutes, is just talk about a situation from that perspective of what if it's a situation of domestic violence. And I wanted to start with, just just acknowledging that we still live in a world where we're separating people and issues into piles that have different definitions, and that attached to those definitions are very different groups of people and sectors working on the issues. And the problem is that violence in relationships, trauma in a life, happens over the course of a whole life. And so things don't happen in, sort of in distinct ways. But right now, when we talk about violence in relationships, we can be talking about violence between intimate partners that can be called domestic violence, but it's specific to couples. Elder abuse is a whole other sort of category now that focuses on the older population. And, there's problems with the idea of calling it elder abuse because there are collectivist communities have other connotations, like other meanings for the word elder. And so definitions and language are very important. And yet we're kind of stuck in definitions and categories that are generally used by governments to identify program areas. And then there's also family violence, which can take in sort of a broader degree of violence that can include domestic violence. And so who is actually committing these crimes, varies between the categories as well. So it can be the intimate partner in domestic violence, elder abuse. It can be sort of it's a bigger group of people. And then family violence, again, sort of a larger group. But we do find that our understandings of situations in lives are often determined by the categories in which we find ourselves working. So let's just sort of acknowledge that as a place to start. One of the things I want to acknowledge is that when we're talking about domestic violence and elder abuse or senior abuse, it's challenging because within the world of those working with older adult abuse, when I first started working with them in, it's a few years ago now, one of the things that surprised me was when I was told that domestic violence has not sort of been considered to be in that category of older adult abuse. That in a way, it is kind of a marginalized issue within that category. And so people will talk about domestic violence as having grown old, as if somehow that makes it less important or part of the whole category of things. And so people experiencing domestic violence in their older years are facing different kinds of being kind of outside the dominant system's kind of way of looking at things, and may and as a result of that, experience barriers, even more barriers to the issue itself. And so that's a little bit what I want to talk about today is you know, sort of bringing domestic violence in an older couple more alongside some of these sort of larger discussions that are taking place with respect to the health and well-being of older adults. So we're going to look at a story, a video story now, where it's a same-sex couple, and Nina has been brought to the women's shelter by police. An assault has taken place, and her partner, Anjou, has been diagnosed with dementia. So go ahead and play that.
Mena, I just want you to know that you're safe here and that I'm just here to listen without any judgment. Anything that you share with me is confidential, unless you give me consent to share it with others, or unless you're at risk of harming yourself or others. Then I have to get you the help you need.
Well, Andrew's illness and her mental state are getting worse. I don't know how much longer I can continue taking care of her. But she won't pay for any extra help. She controls all of the money because she used to work in the bank. And I only work part-time, and I had to take care of our home. But now Andrew says she won't pay for any extra help. She says that's my job to take care of her.
And I understand that Andrew has threatened to hurt you?
Well, she only hit me with her cane. It wasn't really that bad. But then the police came and they brought me here. I don't know why. I just want to go home.
I understand that you want to go home, but it might not be safe to go home right now. Why don't you stay here until we can get things sorted?
Thank you. Okay, so Rayanne, are you there? You're going to ask a polling question now?
Yeah, Rochelle is going to post the polling question up.
Is posted. So what is your number one priority for response to this case? You can select one of them. Number one is managing Andrew's responsive behaviors. Number two is making sure Andrew has care in place. 3, maintaining the safety of Mena. 4, exploring the history of the couple's relationship, including, oh, that got...
That's all right.
Okay. It got knocked off, I guess, including, you know, their history. And then 5, charging Andrew for domestic abuse.
So I realize that, you know, it's kind of probably different things, not just one, but if you could just indicate sort of what do you think sort of the number one priority for you is going to be going into looking at this situation, just based on the information that we have.
Yeah, so we've got 51% of people that are voted, so we'll give you another 20 seconds and then we will close the poll.
Okay, so what do we got, Rochella?
So it looks here, let me share it. We see that 75% of the people want to maintain the safety of Mena, and 12% want to make sure that Andrew has care in place. 10% want to manage Andrew's responsive behavior, and 4% want to explore the history of the couple's relationship. And nobody's interested in charging Andrew for domestic abuse.
So that's, and so again, I recognize that likely it'll be a compilation of those things, but it's interesting to see, you know, where we start from in a situation like this. So thanks everyone for participating. Can you go to the next slide? Great. And so what do we actually know about this situation? We know that Mena was assaulted by her partner. She's the caregiver. We know that Anju is controlling the finances just based on what the information that Mena has provided, and that she's making the decisions about her caregiving with an expectation that Mena is going to provide all of the care. Mena has a cane and some mobility issues. So those are sort of on the surface, the things that we know about this situation. And so, does this, what about this situation speaks to it being about elder abuse? Just go ahead and cycle through the different pieces, Rayanne, right? So healthcare is likely to be involved. Justice is already involved. There's been a charge laid. Violence against women sector is involved. She's at a shelter. What social services may be brought to bear or involved? Home care, who's going to be, with the sort of the advancing dementia, is there home care going to be happening? What are the mental health issues? And so this is a picture of one situation where you have multiple parts of the system that could become involved. And this question about where do we start from? How do the different sectors approach the situation is part of what I wanted to speak to in terms of how do we get to a place where we can speak the same language and see the same, see the same kinds of issues, but also respect the differences that different sectors prioritize and bring to the discussion. It's not possible for us, I think, to do sort of, to have a discussion from any one of these places. It's like we need the perspectives from all the way around about what's happening and what are the risks what kind of risks are we talking about, and how to support people in the situation. So I'm going to talk about, sort of from the violence against women perspective about assessing risk of this situation. I just want to say, though, that I'm also interested in how other groups approach risk. And so, the first question is there a history of domestic violence with this couple? And then, if there is, then what are the primary, secondary, and victim-focused risk factors that are occurring? And this is sort of a list of 40 risk factors that have been developed by the Ontario Domestic Violence Death Review Committee, looking at case studies over, a serious number of years that have allowed us to create sort of this evidence-based approach to looking at risk of domestic homicide in situations. So primary risk factors refer to, what's happening in the situation that's recent or escalating, and they indicate that the person who's engaging in the abusive behavior is also already engaged in violence or is thinking about it. And so there's quite a long list there about it goes from this slide to the next. Primary risk factors, sort of include the following pieces. I'm not going to read the list. Well, if you just want to take a second and kind of scan through it, you get the sense of, sort of what is included in that in primary risk factors. Go ahead to the next one. Secondary risk factors are the circumstances or conditions that are related to the individual or the relationship that can contribute to increased risk and violent or abusive behavior, right? So actual or pending separation, abuse. It's interesting to see sort of the child piece coming into this with what we know now from the ACEs studies in the States, the adverse childhood experiences, that the impacts on kids who witness domestic violence go right through the lifetime and have, serious impacts on people's health and well-being, but also on their employment records and on their experience with violence as victims or perpetrators as adults. Go ahead. And you can see again, it's a long list. And this is not, I'm going to say, this is not the complete list. It's but it's a lot of the secondary risk factors. And then the third category is the victim-focused risk factors, which are related to the victim survivor's vulnerability and include sort of her innate sense of danger and the complex networks of needs, problems, and social circumstances. So they can contribute, these factors can contribute to elevated risk who are already experiencing vulnerabilities. So, being afraid of the person, an inconsistent attitude or behavior, ambivalence about the situation, inadequate support or resources, unsafe living conditions, and then this list of, other elements, including things about where people live and how they regard the system. Because I think that, also we recognize that people who, that the majority of the population actually doesn't seek services in dealing with violence in relationships, or that they're more likely to try to sort things out on their own, which is, why I come back to the importance of working in the community with neighbors, friends, family members, co-workers. Okay, so let's think about this. The other piece that I want to add to this, so that we're not just looking at risk from the perspective of the individual, we need to take a step back and look at the larger system in which Mena and Anju are living. And this is a diagram from the World Health Organization, who have been saying for a very long time that violence in relationships needs to be considered, from a whole system view in terms of the ecology of what's happening in relationships. And so at the societal level, what we see in this case is, like always, when we're talking about older adults, we have to see that the world that we're living in is fundamentally ageist in so many ways. It's so pervasive, our ageist attitudes and our fears about getting older, our fears of death, and the ways in which we, as a society, focus our resources on younger populations. And so ageism is pervasive, and one of the ways we know that is that there's very little research around abuse of older adults to help us develop effective strategies and to even know really what we're dealing with. So gender sits right beside there. In a world where being female is a risk factor for higher rates of violence and abuse, gender, the way we look at gender in relationships is important, and yet there's still a lot of resistance to us looking at violence as a gender-based issue. And I think that, some of the things that we have to get over is this sense that if we're going to talk about gender, it means that men aren't included, and that is not true. What we know is that men and women do experience violence, and they cause violence, but it happens in different ways. And so if we actually are going to develop effective strategies and tools to address violence in relationships, then gender and understanding that violence is a gender-based issue requires us to apply a gender and I would say an intersectional lens on any kind of research that we're doing. And that means that we have to become more familiar, aware ourselves of the ways in which, these categories impact on individuals. We live in a racist society, and there is ongoing oppression in many ways. And what I say when I'm talking to people is, we have to kind of also get over ourselves in saying, you know, I'm not a racist, or no one wants to be these things. But when you grow up in a society that is structured in a way in which, you know, racism and ageism and discrimination takes place, there's no pure place to stand outside and say, I'm not that thing. We are all implicated. And I think, you know, one of the ways forward is that we have to be willing to look at the ways in which we all contribute to the society, the mix that we're in. So ableism is an issue. You know, accessibility. In Ontario, the Disability Act that is supposed to be making the world more accessible is slow going. People deal with accessibility issues every day. And homophobia is still such a big issue, and we're seeing lots of backlash right now sort of around all of these areas. And so at a societal level, we're dealing with, people are dealing with issues that impact them in profound ways that, you know, we may not be so aware of because we're kind of, it's like the fish trying to be aware of the water that we're in. You're only really become aware of it when somebody takes it away. So the cultural context of society is, you know, has each of these issues. At a community level, you know, with Mena and Anju, we can look at, you know, do they live in a community of affluence? How much crime is in the community? Is it easy to get around? What are the mobility issues? Is it a diverse community? And at a relationship level, we can think about how, you know, what's their economic status? Is there history of violence? How long have they been together? Do they have a social circle? And then we looked sort of more intensively at the individual level, thinking about primary, secondary, and victim-focused risk factors for domestic homicide in this case. So if you'll go to the next slide. Oh, right. And so what I wanted to say was that there's risk across all of these categories, different kinds of risk. And so assessing risk is, you know, asks us to take in sort of all of these different elements and to respond to individuals, you know, from a place that's sensitized that to the, you know, to this fundamental idea that violence in relationships is not just an individual issue. But I want to suggest that with all of these pieces, this is, you know, all of these things, you know, puts Mena in a particular situation with all of the sort of the risk factors we've been talking about, and her partner has dementia. And so if we come back to, you know, looking at Mena as possibly living in a situation of domestic violence that may have been ongoing. You know, there may be a history there. It's not just a situation that's one time. It's been ongoing. Then we want to look at it through this lens of, you know, what's the risk for domestic homicide? And if you check sort of through what Mena told us, you can see that, let's assume there is a history of domestic violence. And so there are a number of primary, secondary, and victim-focused risk factors showing up in this situation that should be considered before we move to any kind of safety planning. And again, I just want to say that, and in addition to sort of the individual factors that we're talking about, she's a racialized woman with a disability living in an abusive same-sex relationship with a partner who has dementia. And so, you know, there is so much risk at all different levels that need to be considered in terms of developing effective supports and just thinking about the whole of the situation. And so, you know, how do we deal with all this complexity? If you think back to the slide I showed earlier, where we're all in different kinds of places in a system, how do we deal with, you know, the many different pieces? And I think that, you know, the worry is just about how overwhelming it can seem. in a person's life. Like where do you even begin? And so I had a couple of suggestions, really. You know, everyone working with seniors needs training to be able to recognize warning signs and risk factors of domestic homicide. And, you know, we've already sort of started, like there's been lots of work done in the province. There was a universal screening that was introduced into hospitals. Healthcare providers ask a question about domestic violence routinely. But the problem with that is that we haven't done the support that's needed with that to take it beyond just a question that's asked. And so my experience has been in hospitals that I do get asked the question, but often I'm asked with someone who has their back to me on a screen, and they'll say, I just have to ask you this question. You know, like I think that we have to increase our sensitivity to the issues, and there needs to be more training. I also think that we have to use validated tools and train professionals to assess risk. When you see sort of how complicated these situations are, I really do think we need to be engaging people in situations of domestic violence to help us do sort of the assessments about what's happening. I also think that this is a moment in time where figuring out how we can work together from very different places can be supported through work that's been done by the federal government. This is one project with a website, Equip Healthcare. They have a really good toolkit, and sort of the central idea is here. Getting to an equity-oriented focus in the way that we do our work from very different places. And so the feds have invested significant dollars into developing curriculum and tools around health equity. But equity is a larger social justice goal that applies to all of us working anywhere in the system. And so, you know, it provides a kind of a common language and I think a way of approaching situations from a common ground. And the three sort of main pieces of equity-oriented care is around harm reduction and the ways in which we work to reduce harm in situations, cultural safety that recognizes that cultural differences are inevitable, and that, you know, in some ways we have to become comfortable with differences that we can never really fully understand, and that is possible to work sensitively with people without really understanding the differences. We have a tendency to want to boil things down to things that are the same, things that we can grasp. But the world that we're living in now, I think, demands of us to respect differences in ways that we can't really make our own. And so it's a lot of learning that we have to do about how to work effectively and, you know, respect differences. And then taking a trauma and violence informed approach lifts it up beyond sort of strictly an individual level of trauma and how we see trauma happening, to understand that trauma is an effect of a whole society where structural violence is kind of embedded into the system. You know, right from things that we see, like how long does it take to cross the road? Who decides how long it should take a person to cross the road with the little blinking lights? The entire system is structured around ideas and ways of working, policies and procedures, right, that impact people differently. And so part of what we have to do in order to become equity oriented is to understand the ways in which the system itself creates barriers for people. So I think we can become equity-oriented as individuals. I think it's a strategy. I think that we need to engage our organizations and communities in order to be the change that we want at all levels of the system. We also need to draw attention to the lack of research for older adults as an indicator of the pervasive societal ageism. It's unacceptable. I want to just finish with another little twist on the discussion about dementia. And so this was an earlier slide that said, that pointed to the fact that women are most often that have higher rates of dementia. And go to the next slide. One of the sort of emerging pieces of research supports this idea that we need gender-based and intersectional research. This is Dr. Donald Weaver's work. This is an article that was in the paper this week around studying the potential link between dementia and domestic violence. There is sort of an increasing body of research that talks about head trauma and the impacts of women who have experienced blows to the head over a course of a relationship as being part of this higher group of people experiencing domestic violence. And so we have to find a way to collapse the sector differences that keep us talking about dementia and domestic violence kind of in isolation, and find opportunities in our communities to talk together about how these issues are overlapping. And I think that sort of this more holistic approach about looking at violence along the course of a lifetime, looking at trauma, understanding that most people have experienced trauma of some kind, and that we can approach them with sensitivity to understanding that people's social location makes a big difference. We can understand those things without knowing the details of a person's life, and that sort of working toward a more sensitized a service professional community, and also just the broader community, are good goals for us to set for ourselves. And so, what I was interested in was sort of what bubbles up for you, with this discussion, because, I think that both Sarah and I and Rochelle, we've given you sort of different bits of information. What I'm interested in is what comes next. What are the conversations like in your community? Are you talking about these things? And can you point to examples where different groups are, doing very cool things, that kind of bring these things together, and that provide ways for us to think about working together across the lifespan?
So thank you everyone for great presentations. And we have the opportunity for people to write into the question or chat box responses or ideas that Margaret just addressed. And while you're doing that, I'm just going to go back to a couple questions that were asked during the webinar. And just sort of, if we're going for the beginning, we're talking about imminent physical risk. So somebody had a question, if there is any imminent physical risk, do you call the police? I know Sarah and Rochelle can all respond. So if there's, obviously it's an emergency situation, we would not discourage anyone from calling police if there was harm to an individual.
I would just add that the police themselves will tell you that they would rather be called. Like if you're sitting in a situation where you think, should I be calling the police? They would rather that you call, like trust your gut when you feel like a situation is dangerous.
Right.
I think people get worried about confidentiality, but in the Personal Health Information Protection Act, if there's imminent risk of harm to self or others, you can disclose that information to the police or call for an ambulance.
There's another question. If a power of attorney exhibits abusive behavior towards that elder, and then a capacity assessment is done after the abuser has POA and this client is deemed not competent, does that mean that the POA has complete control, or does the client have to revoke POA before the capacity assessment is done? I think that's kind of more specific to financial abuse. And
yeah, so if
the question,
if a person is capable, they can revoke a power of attorney for property and finance, or a power of attorney for personal care. So if you're capable, you can grant someone to be your power of attorney. You can also revoke it. If you're not capable, and the power of attorney or the substitute decision maker is the one that is exhibiting abusive behavior, that's when you contact the Office of the Public Guardian and Trustees, and you contact their guardianship investigation unit.
Right. Sorry, I'm just going to go through here. It's just a comment. Seniors are treated as invisible in most of our communities by politicians unless we become vocal and involved, was one comment. We haven't had any other comments.
There's a chat here. Where can you find information if a long-term care have reported of an assault happening in a retirement home or long-term care agency? Okay, so if you're looking for, it sounds like you're looking for reports. So if you go to the Ministry of Health and Long-Term Care website, you can look up different long-term care homes and you can see if there have been any complaints. If those complaints have been verified, what was the nature of the complaint? Was it medication mismanagement? Was it that they had a higher amount of falls versus the provincial average rate? And then similarly for retirement homes, you go to the Retirement Homes Regulatory Authority. They are the ones that license all of the retirement homes across the province. And you can look up the different retirement homes and see if there have been any compliance issues. So all of that is made public record. So you go to the Ministry of Health and Long-Term Care website for long-term care homes and Retirement Homes Regulatory Authority for retirement homes. And I think we may have, do we have that in the resources, the website for it?
Yes.
I think we do, yeah. So in the slides, if you go under provincial information and supports, there is the website for both of those different agencies.
So just getting back to Margaret's idea and thoughts of this issue, we're part of this webinar is, we can't just sort of jump into safety planning without knowing some of the assessment of the risks and how we do that, and just getting sort of an idea of other communities if they are working with other collaborative partners in terms of assessing that risk, and if you're using one specific risk tool that you find that is helpful in some of these complex situations. We would like to know sort of what you're using and how we can share that information if it's being effective or not. So someone asked, what's the difference between elder abuse and family violence and domestic violence?
Often it's, well, it's defined usually by who's causing the violence, right? And so right. That was what we talked about earlier. But I think that also there's different, like when you look at the funding streams, they're quite different, right? And that's the thing that I think keeps us working in different parts of the community on issues that really should, consider sort of the whole lifetime.
I think it's also important to recognize that, for example, an older woman could be experiencing intimate partner violence perpetrated by her partner. She could be experiencing elder abuse perpetrated by a PSW or the person that's delivering the Meals on Wheels. She could also be experiencing family violence or also including elder abuse perpetrated by her adult children or grandchildren. And when we think about the different relationships, our response to those relationships and the nature of abuse is going to be different. So as Margaret alluded to, there's a lot of different programs available for people who are experiencing intimate partner violence, but there may not be as many resources for a person that's experiencing abuse that's been perpetrated by their adult child or by a service provider.
Well, and we know that even within the violence against women sector, for an older woman seeking supports, like that entire sector is talking about how do we support older women seeking services, because the sector has been geared to a more of a younger audience. So these are systemic issues that we have to that we have to work through.
So
And,
just getting
just
back, oh, sorry, go ahead.
no, it's okay. I lost what I was going to say. Forget it.
So just as a follow-up, this in that discussion about the differences between this family violence, elder abuse, and intimate partner, they were just saying about asking about in relation to the actual definition.
Mhm.
So I'm not sure the definitions. I'd have to go
Well,
back to
you're
the.
going to get different definitions depending
Mhm.
on depending on funders, right? So generally, they're government definitions.
So there's another question here is what is the difference between responsive behaviors versus coercive control in abusive relationships?
Oh, thank you. That's such a good question. And this is one of the places where, like, I don't know how to answer that because, when I hear Sarah talking about responsive behaviors, I completely appreciate, this sort of the idea around violence happening when someone is trying to communicate, who's having difficulty doing that, or people aren't listening to them. And in the context of Mena's story, a partner that has dementia, has assaulted her. And so that is still, violence within an intimate partner relationship. And so the responsive behavior is also possibly a pattern of violence that's occurring in that relationship. So that's a little bit why it's difficult to, think about these things in strict, as being different or separate.
And Linda Reimer, who is involved with who's a forensic nurse, actually was talking about the risk tool of the ERA, which is the Elder Abuse Risk Assessment, and which was developed by Jennifer Story and another colleague out in BC, and just asking about that tool. And we have done training about a few years back around that tool, but people, it's not as accessible, unfortunately, to the general public. I could look into seeing if they've released that, but we haven't had the access as a public tool to utilize. But I think it is a good tool. So I will look into seeing if it's a public, it's accessible now.
Mhm.
I wanted to add one more thing that I remembered what I wanted to say a couple of minutes ago. I was thinking about the 2014 Domestic Violence Death Review Committee report that profiled 4 cases, 2 of which all homicide-suicides, I believe. 2 cases had a history of domestic violence, but 2 cases did not. There was no perceptible history of domestic violence in the relationship, and yet it was a domestic homicide-suicide. And so we don't know a lot. Like, I think that we need to, when we're calling for research or talking about research, we need to understand sort of the overlap between situations where deteriorating health is, creating these conditions where a homicide, suicide become solutions to the people, to the couple at the center of what's happening. This is like the canary in the mine shaft that we need to, I think, be making more visible and talking about more deliberately around how are we responding to risk in a variety of situations that are particular to older couples. Like, there are risk factors, that we know that are more dominant in older couples. Depression of the person who's causing the violence, and we also know that a couple that is experiencing the rate of homicide suicide is higher in older couples. And so those of you who are watching sort of for suicide ideation, are you also thinking about if there is domestic violence happening, looking at the sort of the lethality factors that we talked about earlier? These are really important convergences that I think require us to build cross-sectoral relationships right in our local communities that are able to address the complexity of these situations. But we also need research.
So one of the other questions was, what are some of the risk factors associated with domestic violence and the importance of past trauma?
Well, past trauma is really significant to everybody involved. Like more and more, we're understanding, the world in some ways. Everybody's experienced trauma of some kind, and it does, depending on. It doesn't excuse violent behavior, but it certainly underlies, the dynamics in families. Untreated trauma is something that is quite pervasive. Learning about the risk factors, we do that with the It's Not Right campaign, but there is lots of information that's available online as well. On our website, the center website, you can access domestic homicide death review reports and look at the recommendations, and you can find sort of a list of risk factors on our website. So, learning.
Thanks. So if there's any other questions, you can put them down. I'm just going to continue on. This was the tool, I believe, that Sarah, you were referring to?
Yeah, exactly. So we've got some really fantastic resources to help people live safely in the community, and there's a really wonderful guide that you can access. It's called How to Help Someone Who is Lost or Confused, and it's a practical guide. There's also one that's called Living Safely with Dementia. It's a resource guide as well, and those can be accessed as well as the online learning portal that you can see here from the findingyourwayontario.ca website. And there's all kinds of downloadable resources. They're printable resources, or you can always pop by your local Alzheimer's Society because they're available there as well. So that's really fantastic. The Shifting Focus booklet that I mentioned, you can visit shiftingfocus.ca. And in addition to there being the long form, there's also a short a booklet that you can download and print off. You can also order those resources as well. And it's kind of a quick guide for family members and care partners of the do's and don'ts. When a responsive behavior does occur, what's helpful and what is not helpful. How do we change our behavior? How do we change the way that we approach that situation to get the best results? So that's great. Those are great resources, and I encourage you to visit those sites. And of course, the next slide also shows some other links and different ways that you can connect as well. There's there's online courses that I highly recommend. The Alz Educate link there that you might see on your screen, and there is some great online learning. If you want to enhance and increase your understanding of dementia, there's a series of modules there that you can go through. It's really nice interactive online learning. And I've had so much positive feedback from people that have participated in those courses. So lots of different links there to check out, and of course, you can always visit the Alzheimer's Society in your area for more information, more resources.
Thank you, Sarah. We also have our safety planning toolkit, which I had mentioned earlier, and that is available on our website under our training and under intervention tools. And we did have an adaptation, as I indicated before, with issues around dementia and safety planning. So I'd encourage you to go and access that or look it up. And as I say, we'll be continuing to update that as we move forward in the new year. We do have our senior safety line that people can access, or seniors can call 24/7, and it is available in 150 languages. So people can get access to resources and services within their area if they're not sure where to go to get support and assistance. And I'm not going to go through all of these, but these are some provincial phone numbers that you can have access to that's available on the slide deck that we'll be sending. The Sexual Assault and Domestic Violence Treatment Centers, this Victim Support Line, the Assaulted Women's Helpline as well, the Talk for Healing for Aboriginal women. Individuals can get support, Rainbow Health Ontario, focusing on LGBTQ older adults and individuals. And then the legal support in terms of Law Society of Ontario and the Advocacy Centre for the Elderly, of course, Alzheimer's Ontario. And as Rochelle had mentioned, the RHRA and the long-term care home action line, that people can report as well. So I'm not sure if there's any other questions. Before we leave, though, I did want to let people know that we are going to be having our part 2 series, because someone did ask about who's going to be talking, if we're going to be talking more specifically about safety planning. And we will be holding another session looking at this issue in perspective from the Violence Against Older Women sector, as well as the Behavioral Supports Ontario. Oh, I spelled Ontario wrong. So we are working on firming up a date for that, and we will let people notice in regards to this date, probably early January. Rochelle, do you want to say something?
Yeah, so we're working with, we sit on the advisory for Aging Without Violence, which is being funded by the province of Ontario and sponsored by OAITH, the Ontario Association for Interval and Transitional Houses. And they have a 4-year project dedicated to looking at abuse of older women. And they have a great advisory full of, different stakeholders from different sectors. So we hope to have Aging Without Violence and the behavioral supports community outreach team. So we're just trying to firm up our speakers for the second webinar. And, they'll to speak more to that question around the difference between responsive behaviors and coercive control. I think that will be an ongoing situation that we would have to assess, case by case, because we really have to look at the pieces and the history, behind the person with dementia, as well as the nature of the relationship.
Sarah, there was a question. Are there available resources for young onset Alzheimer's or dementia?
Yeah, it's an area that we're starting to see more information coming out of. But yeah, up until now, there hasn't been a lot. You can always check with your local society. But if you go online and onto the Alzheimer's Society of Canada webpage, there is information there about young onset dementia. And I appreciate that you called it young onset dementia as well. We've kind of moved away from calling it early onset dementia, but young onset dementia, we are seeing something around the neighborhood of 16,000 people under the age of 65 in Ontario that are living with dementia. So, we're finding ways, we're finding more, education streams and support streams to be able to support individuals that are younger, that are facing living with dementia.
Great, thank you. Just before we wrap up, I do want to remind people that you will be prompted at the end of the webinar to just fill out a short evaluation form just to give us feedback, again, giving us information or topics that you would like to see at future webinars. And we encourage you to go to our website just to check things out. And if you have any questions, you can contact Rochelle or I. Our emails and phone numbers are located here. So thank you again. And just as a reminder, the PowerPoint and the video audio recording will be uploaded to our website within the next day, and so people can have access to that. And stay tuned for our next webinars. Thank you, Sarah. Margaret had to leave, unfortunately, and to Rochelle.
Thanks, everyone.
Thank you, Leanne. Thanks, everyone.